Great. All right, what do you see now, Sandy?
Perfection.
Isn't that good? Okay. All right.
Excuse me.
That should be good.
Get that out of the way. Give her a Diet Coke, you know. Right. Okay, welcome back, everyone. So to this session, we're going to do 2 lectures. The first one's going to be broadly about systematic reviews, why we do them, what they're for, and how we should do them. And then the second one's going to be more about meta-analysis, which is one of the key statistical outputs from a systematic review. We don't always do them, but the good thing about meta-analysis is it sounds dreadful, but as a user, they're really easy to make sense of and understand, as long as they've been fairly presented. So you remember from the hierarchy of evidence that right at the top of the pyramid, above RCTs, was systematic reviews with meta-analysis of RCTs. And the point of that goes back to the lecture yesterday, that no trial on its own is an island. It sits within a broader context of evidence that pertains to that question that you're trying to ask. And so if you're trying to ask a question, does this intervention work for that outcome in that group, then you don't want to look at an individual trial if there is a history of trials on that topic. You want all of the trials. And that's the whole point of a systematic review, is you're trying to identify all of the relevant evidence on that topic, and you'll go to great lengths if you're doing a good review to try and get hold of it. And then you're trying to bring that together. I remember we said yesterday, you know, any individual clinical trial is an attempt at estimating the truth. And so if we're talking about whether this intervention is effective, that's one attempt at estimating whether that intervention is effective compared to a comparison. And it will give us an estimate with some measurement error and some bias about what that effect is. But if we really want to get closer to the truth, then the more of those estimates we can get together, then the more likely we are to get closer to it. Back in the late 70s, actually, Archie Cochrane, who was an epidemiologist and after whom the Cochrane collaboration is named, he wrote that, you know, it's surely a great criticism of our profession that we've not organized a critical summary by specialty or subspecialty, adapted periodically of all RCTs. And the point he was making is, you know, we have these trials, but why aren't we bringing them all together into some grand repository and assessing them and taking some proper approach to trying to synthesize them and then updating that as the evidence base updates. And just to give you an example of how that might have changed things for some people, that might have been important, here are data from Vioxx. Do people remember the Vioxx story? So that was a COX-2 inhibitor, non-steroidal anti-inflammatory drug that got rolled out pretty broadly because it had better gastroprotective profile than non-selective NSAIDs. But it was found to increase your risk of myocardial infarction. But that was found quite late, and it was found after it had been used extensively. And in a systematic review in 2004, what they've done is they've got together all the trials, and they've done what's known as a cumulative meta-analysis. So as each year's worth of trials comes in, you add that to the effect estimate. You can see, as we get more data, the confidence intervals around our point estimate of the safety of Vioxx reduces. And what we find is that by about 2000, we knew with not very much uncertainty that Vioxx was not as safe as placebo. The MIs were more common using Vioxx than placebos. And because it's an NSAID, that's a drug that a lot of people are going to be on. It's a drug that a lot of people are going to use. So even a low risk is going to lead to a lot of events if it's being rolled out wide. Rofecoxib was only withdrawn in 2004. So you've got a 3 to 4 year period where we had the information that we needed, that rofecoxib wasn't as safe as we had assumed, but we didn't withdraw it till 2004. And the guys who run this review wrote, rofecoxib should have been withdrawn several years earlier. And the reasons why the manufacturer and the drug licensing authorities did not continuously monitor and summarize the accumulating evidence needs to be clarified. Why didn't we do that? Well, we probably do that for all interventions, but particularly new drugs. If we have a look, another example, anyone remember this book or heard of Dr. Spock? Not the Star Trek guy,
yeah,
but pretty much the world's populist expert on baby care, particularly through the 70s and 80s. And this book was a massive bestseller across the world. And one of the things that Dr. Spock recommended was prone lying sleeping for babies. And the theory being that then when babies vomit, they would be less likely to choke because they're prone lying. Okay. And this pertains to the risk of sudden infant death syndrome. So we can have a look at a cumulative meta-analysis here of studies on sleep position and incidence of sudden infant death syndrome. And we can see that actually prone lying is a risk factor. Prone lying is a risk factor for SIDS. And we knew that, really, we knew it well enough by the end of the 70s. But who's bringing this evidence together and coming up with that? So this is from a systematic review conducted in 2005, okay? And it's interesting, they concluded it's unusual for health advice to have a profound effect on mortality and to detect such tragic effects from health advice not based on evidence of effectiveness. It was based on expert judgment. Okay. Had systematic reviews been common practice in the early 1970s, parents, professionals and policymakers would have been aware of the cumulative effect of promoting prone lying to parents at least 15 years earlier than they really were in the late 80s. And of course, the upshot of that is a huge number of preventable deaths in infants. You know? And you can see how the rate of SIDS was increasing and increasing and increasing until we had that cumulative evidence. And then behaviors started to change. Such a simple thing, right? Such a small piece of advice. It speaks to the dangers of plausible expert opinion in the absence of evidence. But it also speaks to the value of synthesizing all the evidence that we have and bringing it together. So the key characteristics of a systematic review are that you must start with a clearly stated set of objectives. Does that ring any bells after the last day or so? Right? What is your question? Predefined eligibility criteria for studies based on your question. And in systematic reviews, no one should design a systematic review protocol without a very clear P code. Right? Gotta have that. We have an explicit and reproducible methodology that is decided upon, as in all good science, before you collect your data, before you search, before you go looking. We do an extensive search for eligible studies, and it really is extensive if you're doing a good review, and it's profoundly tedious and iterative, but it's important because you don't want to miss important stuff. You take a consistent and systematic approach to assessing the quality or risk of bias of the evidence that you identify. And then you go about a systematic process of extracting and presenting data and synthesizing data, which is sort of where a lot of the big challenges actually come in terms of asking a question. What a systematic review isn't is Googling for evidence that proves what you know, or going into PubMed and writing core stability works or something like that, right? It isn't that. It isn't about identifying individual trials at all. It's about getting all of the evidence. What it also isn't is just a narrative review paper. And you know, when I graduated, when I trained in the early 90s, the only journal we had access to was physiotherapy, pretty much, and it was only paper copies. We didn't have it online. And most of the papers in the physiotherapy journal were narrative review pieces. This is what we know about cystic fibrosis. This is kind of what I think about cerebral palsy and how we should manage it. And none of it was really based by evidence in the way we understand it now. Now, that's not to say that narrative reviews aren't really useful. They are. They're interesting. They can present consensus, a little bit of state-of-the-art knowledge, show where the industry is on a topic. But what they aren't is evidence, right? They're not evidence, okay? One of those reviews kind of looks like this, doesn't it? You kind of think, well, I'm going to write a little bit about how we should best manage acute stroke. So you'll do a bit of electronic search. You'll already know what you want to say because that's why you're writing it. You'll do a search and you'll find some evidence so you can populate a reference list that makes your argument look more compelling, and you'll organize it into an interesting narrative. Okay, you probably won't look for references that don't support the narrative that you're trying to do. And we all write these things. I've just written down that this is really important. I must find something to back that up. which of course is the wrong way round. We do lots of reading, and then we essentially pull it together into a story, into a narrative. I actually love reading the narrative review. I think they're always really interesting, but they're on the evidence continuum, they're closer to journalism than they are to science, right? And so the problems with them are that they're restricted to what's available in terms of publication bias. They generally don't systematically search. People aren't systematically searching all the literature when they write one of these pieces, so they miss stuff, they're selective. There's no transparency in the methodology to how they got to that narrative that they present. And sometimes it's arguable how much they genuinely contribute to knowledge, okay? And most importantly, though, is, there's not much in the way of quality control going on in one of those, often, and like everyone here's written an essay where you think, oh, I'm going to use that citation because it seems to sort of support what I say. Did you read the paper? It's a citation that supports what I say. A systematic review looks a bit different. In a systematic review, we formulate that research question and we get our PICO structure. We retrieve the literature based on predefined criteria. We have an approach to extracting the information we want from those studies that we apply consistently across studies with protections built in to avoid error in extraction. We synthesize and aggregate those studies using a plan. And that plan was something that we thought, before you start, what's the most reasonable way of doing this? Before you see the data, what's the most reasonable and defensible way of doing this? And you might test a hypothesis. You might be looking to get a grand effect size, as we often are, or it might be that you are just going to narratively synthesize that evidence, but at least you've been systematic in getting there. But it's really important that everything is decided. All the major decisions are decided before you've seen the data, okay? As soon as you start changing your methods or adapting your methods in light of the data, you've got another degree of freedom that's a risk, and it's a risk of bias that you can use that freedom in order to selectively present the data. So it's really important that you have a well-developed protocol. Now, in the last few years, we've got an international register for systematic reviews called Prospero. And if people are going to do systematic reviews, then they're strongly encouraged, just as you'd register a trial, to register your systematic review. And that record should have what the question is, what the PICO are, and how you're going to do it. Just like with trials as well, much more often now, people are publishing full and detailed protocols of their systematic reviews in journals like BMC, Musculoskeletal Disorders, and BMJ Open as well, so that you have that transparent audit trail. Because just as it's easy to deviate and change in a trial, so it's easy to do that in a systematic review as well. A lot of journals are moving to the position where they're saying that they won't look favorably on a trial that wasn't registered. But we haven't got to a position yet where many journals are saying we won't consider a systematic review without a registered protocol. But hopefully, in my view, that's the direction of travel, that they should just be considered to be standard practice. So we know what these are, guys, right? And we've done enough of this, so I'll skip through that. But the point about that is whatever question you're asking, the participants, the intervention, what that really means, and we really went into that yesterday, all need to be clearly defined. And in terms of outcomes, just like with the trials yesterday, you need to have a primary outcome in mind, and preferably a primary outcome in mind. Maybe 2, not 5. But you can have secondary outcomes in there. Okay. You can't do a systematic review on your own. You can't do it, okay? Because there's so much data that you have to sift that the capacity for error is massive. So if you do a very sensitive search of the literature, you're sometimes going to end up with 5,000 citations that you've got to screen. And when you've got an Excel spreadsheet of 5,000 citations, you're good for 10 minutes. And then you stop seeing what's in front of you. Right? So there's lots of things you can do to try and counter that. But one of the things you'll do is you'll make sure you have 2 independent reviewers doing all this stuff. So 2 independent reviewers will scrutinize the searches and screen them for studies that are clearly irrelevant and then studies that appear that they might be relevant. You then source the full text of those studies that aren't clearly irrelevant, and you're quite inclusive there. So if it looks like it could possibly be relevant, you keep it in. It's only if it looks like it's completely off topic very clearly, and there'll be a lot of that if your search is sensitive, that you dump it, okay? So then you get the full text, which can be difficult in itself. You've got paywalls, you've got international journals that sometimes aren't that easy to access. You've got journals you've never heard of as well. You've got all the predatory journals now, so there's much more stuff, but you've still got to include that stuff because you don't have a clear list of which journals are predatory and which ones aren't. So then you get all those full texts together and you formally apply your inclusion criteria to those full texts. But again, people do that independently. And after they've made their decisions, come together and look for agreement, disagreement, discuss that. If they can't come to a consensus, you'll have a third reviewer normally in reserve to help resolve any conflicts. It doesn't normally come to fighting.
Can you screen
I think the point is it's actually a really grey area. There are a couple of publishers that certainly would have been considered to be predatory 5 years ago, that now people are starting to take seriously, I think mostly by virtue of the fact that they've existed for a while and people have started using some of their evidence. And some of them get indexed on major databases. So at what point can we prove or say for sure that something's predatory? You have suspicions though. Once you've got the studies that you want, then you've got to decide, well, what's the quality of this evidence? What's the risk of bias in this evidence? So you'll use a tool like the Cochrane risk of bias tool that we were talking about yesterday, or like the Pedro scale, to go through the criteria and whether things are reported, whether they're reported clearly, whether they did those things that we know make a good trial. And then you'll extract the data, but again, you'll have a very specific plan and a pro forma for that. And two reviewers will do that independently and then come together and look for disagreement or error, so that you're kind of protecting each process, one from the individual doing it unchecked, and two from the fact that we all make mistakes. When we're searching the literature in systematic reviews, thoroughness is everything, right? So if you see a systematic review that says we did a search of PubMed, well, they haven't looked at everything. PubMed doesn't have universal coverage of all the potential literature. So you have to be looking for multiple electronic databases to get better coverage. Okay, and that, of course, will get you all the published stuff. Hand searching is another thing that you might do. So one of the things that we generally do routinely at Cochrane is, once we've got our list of included studies, we'll then hand search the reference list of all those included studies, two people independently, to look for anything that might not have come up through our searches. But, you could hand search forever. You could go back historically to literature that was there before PubMed really was a thing. We don't have to do that so much now. 15, 20 years ago, databases weren't what they are now. But as coverage gets better, the role of hand searching decreases, which is good for us. I think, you wouldn't want to do a systematic review in the late 90s, frankly. It would have been horrific. But now we have databases, and databases are ace. But of course, they're really only going to get you the published literature. And we've been talking about publication bias on the course already. How do we find that? How do we find studies, or try and find studies that were done, that asked the question that we're interested in, but weren't published? And there's a few things you can do. Go on. Right, okay, so the first place we might go looking is the trials registry. So we've searched the trials registry for studies that were registered on our topic. And then you can see, well, which ones have been published? Have I found a paper that relates to? Which ones haven't? And then generally you're emailing the authors, the contact person on the registry, to say, what's the status of your trial? Trials registers are good and bad. They're a great idea, but they're not regularly updated in the way that they should be. And the audit trail is normally pretty incomplete. I don't know if you agree with that, Steve.
Yeah, I do. The other thing to add is they're relatively recent.
Yeah.
So it's fine for stuff which is done recently, but 10 years ago, they're hardly a thing.
Yeah, absolutely. The other place you might go looking is the grey literature. What's grey literature? Stuff like PhD theses and dissertations and conference abstracts and all those things. It's an absolute fight searching for those things. Getting hold of the information is often a nightmare. You often do a lot of work for very little return in a way of usable evidence. But the important thing as a researcher is you're trying to access everything that's accessible. You're trying to get all the relevant information. And you're also trying to get a sense of how much information is missing. which is, we've recently updated a Cochrane review on non-invasive brain stimulation. And there's a lot of registered trials that haven't yet been published, which is interesting because it corresponds with some of the signals that we see in the data. And you need a search strategy. So, I guess when you guys are searching PubMed, you'll just throw a couple of terms in, right? And hopefully see what comes up, and you might do a few different ones. When we design search strategies, it's really good to have a good information specialist on your team, a librarian who kind of does this stuff for a living, because search strategies get quite complicated. But we generally find terms that fit into each of our PICO criteria in order to help us to better identify stuff. But we're generally going more for sensitivity, get everything, than specificity. We'd rather not risk missing something by using quite restrictive terms. Okay, so you might organize it into these PICO categories using Boolean operators. People familiar with that? So if I was to use the Boolean operator or and throw a few terms in, then I'm going to get everything that used any of those terms, right? And once you've done that, then you can combine them using AND to try and make things a bit more specific. Some databases have mesh headings. People familiar with that? Medical subject headings. So if you go onto PubMed or Medline, then they've organized and indexed stuff by keywords. So for instance, if you put in pain and explode the word pain, then you'll get everything that's been linked to that word. If you're doing cancer, you'd put in neoplasms and it will just link to everything that's been linked. Of course, it's not perfect. Some things won't have been linked because there's such a vast amount of data, but it's a nice shortcut to trying to explode the sensitivity of your search. And you can use all sorts of fancy tricks like truncation symbols, wildcards, and proximity indicators. So none of that makes much sense until you see a search. So this is a partial section of a search that we've done in the past. And we were looking at non-invasive brain stimulation techniques for chronic pain, right? So let's have a look here. I'm going to highlight bits and ask you what you think they are. So what do you think this is? X pain. Explode pain. So pain is a mesh heading in Medline, right? So we explode it, and the number is the number of hits we got off the back of that, okay? The next thing, you'll notice that all of these terms under section 2 and 3 are all potential descriptors of chronic pain conditions, yeah? The reason we've separated them into 2 and 3 is because there's so many of them, the database can't handle us putting them all into the search at one go, okay? But, so we've got chronic or back or musculoskeletal or intractable. And you see we're combining them with all because we're interested in all chronic pain conditions, right? What do you think these highlighted things are? Totally. So they're wildcards or truncation symbols because some words have lots of different suffixes, and you want to capture them all. So it's just more sensitive to use something like that, where a word might end differently, but have a similar meaning. Oh, that's not a very good colour. Do you see what I've highlighted there? AG4. So diabetic AG2 neuropathy, reflex AG4 dystrophy. AG. How many words start with AG? These are proximity indicators. So if I do diabetic AG neuropath, then I'll capture any record where the word diabetic came within 2 words distance of neuropath. So if people have thrown words in between, it will capture those too. So you see, it's just another way of increasing the sensitivity of what you do. What do you think this is at the end? .ab.tie. Guys, really, you kick yourself. .ab.tie. These are the domains, the fields in which I'm searching. Abstract and title. Right? And so you'll notice then that what I've done is we've combined all these potential diagnostic terms with OR, and then because we had to put them into separate searches because of the database, we combine them all with OR. Then we do the same with potential terms for the intervention. Yeah? And then we take all our diagnostic terms and all our intervention terms at the bottom, and we combine them with AND. So I won't get all the ones that say chronic or back or musculoskeletal now. I'll only get the ones of those that will also, that also had these terms in. So I'm only going to get the records where I had both one of my interesting intervention descriptors and one of my interesting population descriptors. Make sense? I mean, this is just a section of that. But actually, when you guys are searching for literature, it's worth banging around with some of these just to see, you'll get much more just playing with them informally. But you must read the guide because each database has different language and might use different symbols to do the same thing. So just look at the tools section. Okay, so then we do our search. We want to be pretty sensitive. We screen the titles and abstracts first of all, kind of eyeball them down and see which ones are clearly irrelevant and exclude those. It might well be that some are unretrievable. So in this instance with brain stimulation, there are a few papers come out of Russia in the Soviet period in the late 60s and 70s that we couldn't get hold of. It's probably for the best because actually brain stimulation studies from Russia in the 60s are often ethically really interesting, delivering doses that we wouldn't consider today and often in populations that don't have their freedom. Really, it's a strange history. So there are a few papers we couldn't get hold of. So then you have a bunch of papers left. So, we start 843, screen down, which is a very low number for initial screening, screen down to 43, okay? And then we screen those against our formal criteria, the full text of those, and we exclude some, but we clearly document why we excluded the ones that we do. Any review that doesn't show you this flow chart and give you reasons in a clear audit trail, so not a marker of quality, you're starting to worry about that review, okay? And then we've included 33 at the end, and they're the types. Once you've got your data, so easy, that's the hard part, then you've got to make some sense of it, right? So we need to assess study quality. You need some sort of validated, reliable process that you can apply consistently. There's lots of tools available. If you look at the different tools for RCTs, they're not very different from one another. Some score, some don't. Pick one that you can use. The CAST tool's not so good for that because it's more about helping clinicians use evidence. But if you're looking at what we're looking at when we're measuring this is really the internal validity of these studies, then use something that's really designed for that. So the Cochrane Risk of Bias tool, I think, is pretty good. Pedro, I think, is pretty good. And there are others, but just find one that you can use.
I just mentioned something that you see here that isn't any good is, and sometimes people will apply quality to their inclusion criteria, and that is arguments for and against that. But sometimes you'll see two or more authors decided a study was scientifically inadmissible or admissible. I've seen this in
I haven't seen that.
And so they'll go through and so they'll have whatever their inclusion criteria, but then they'll have this sort of nebulous thing about scientifically admissible or inadmissible. And again, it's a red flag. Yeah. And if nothing else, it's completely, there's no way of repeating that.
Yeah. I mean, unless you've clearly established this as an inclusion-exclusion criteria and defined it, it doesn't mean anything. My view is include everything. You can deal with risk of bias and quality within making sense of the evidence. Include it and then decide what you're going to do with it based on what you find in terms of this formal risk of bias assessment.
Was there like a huge range of Nazi studies that just aren't ever referenced, and it was sort of a
Yeah, generally not to the sort of questions that we would ask. But I think if you were asking a question that pertained to that, where they might be that kind of evidence, and that would you'd have to delve into the ethics of it and decide. Yeah. It's a really interesting question. Do you use evidence that's been gathered outside of the accepted ethical standards of all the the Helsinki Agreement and all these other things? And my view is no, and I think that's the consensus view, is that you really shouldn't. But yeah, I mean, you have to ask yourself as well. I mean, what's the quality of those data? What it need to be like? But okay, so we've got our tool. We've decided how we're going to use it. So I can show you the risk of bias tool, and it all looks pretty straightforward. Did they blind? Did they randomize? Did they conceal allocation? actually making judgments on this stuff isn't always that straightforward. So a good review will operationalize how it will actually define high, unclear, or low risk of bias on each of those criteria. Then we have our data extraction process. So we've defined in our protocol all the important info that we want. We develop a standardized form. In an ideal world, you pilot that prior to doing the review on similar but not directly relevant studies. So you can make sure the form is doing the job that you want it to do. And again, you design all that a priori, and 2 independent researchers extract the data. So now we've done our search, we've got the evidence, we've assessed the quality or risk of bias of that evidence, and we've extracted all the data. Then we need to bring it together, right? And one key way of trying to bring things together is meta-analysis. I'm just going to introduce it here, and then the next lecture will go into it into a bit more detail. But what a meta-analysis does is essentially measure the size and consistency of treatment effects across more than one study that asks the same or a similar question, okay? And by pooling data from different studies, in theory, if all goes well, we increase both the accuracy and the power of our estimates. So we can estimate not only the treatment effect, but the consistency of that effect between different studies that ask the same question. So that means if we've got all of the studies and we're trying to pull them together, there's less of a risk that we'll reject an intervention that actually works on the basis of one study that showed that it didn't, or a few underpowered studies that ended being a type 2 error. But we've also got less chance of being fooled by falsely positive data. If you've got one landmark trial that shows an effect, but every other trial doesn't, you should be suspicious that that trial might not be representative. I mean, depending on the differential size and quality of those studies, it's always nuanced. And the quality of individual studies is vital. So there's a saying in meta-analysis, GIGO, or as we say in England, RIRO, which is garbage, rubbish, in, garbage out. So if you put crappy studies into a meta-analysis, then you're putting crappy effect sizes into a meta-analysis, and the pooled result you're going to get will be crap. Right? So quality is really important. And actually, again, there isn't a definite rule on when you exclude studies from a meta-analysis based on your risk of bias assessment, but it's something that you have to consider in the protocol. It's a powerful tool used correctly, and hopefully we'll see that in the next section. But it's very easy to do it badly, and it's very easy to do it in an unreasonable way. And you need to be very careful in how you execute and interpret a meta-analysis. And remember, we're not doing it just to get a p-value of statistical significance. What we're really interested in is the size and the precision of the treatment effect, which is a theme, isn't it, of the last few days. So you have to ask yourself, what does it mean? Now, it might be that you can't do a meta-analysis. It might be that it's not appropriate to do a meta-analysis because actually all these trials are so different, you don't want to pull them together. It might be that you can't do it because they don't report their data in a usable way and they don't reply to emails when you start asking them about their data. And we'll always do that. If we haven't got the data we want, we'll email people. I've been emailing the guy since 2009, and occasionally he replies. He's very pleasant, but he doesn't ever give me his data. But I think, you know, if I'll probably still email him when I'm 65 and about to retire, just because it's become like a tradition. I start giving Christmas cards. So a narrative synthesis is really about giving a descriptive summary of what the evidence looks like. It's actually in some ways harder than a meta-analysis because you've got much more in the way of degrees of freedom in how you bring that together. And you've got to balance showing what these studies said against the quality of the studies and other things that might be affecting that evidence base. And it's difficult to do. A lot of studies will go down a road of trial counting. So we found 5 studies, 3 of them said it works, so it probably works. And then give you no further context on, well, how do you characterize the 3 that worked and then the 2 that didn't? And for what reasons should we place more weight on those 3 than these 2? When you see a review making strong conclusions by counting the number of positive studies, remembering that positivity is normally defined by the p-value alone, I think you should be very, very suspicious of that. I don't think it's particularly meaningful. Yes?
I have a question from Jessica. She said, please repeat the question because it helps her a lot. I hope this isn't a silly question, but I just want to clarify. Do systematic reviews and hence meta-analyses apply only to intervention?
No, absolutely not. So if you think of what are we trying to do with a systematic review, we have a research question And we want all the evidence that can really help us to answer that research question. So it could be, do our backpacks a predictor of future back pain in children? And it could be, does smoking cause cancer? And it could be, what's the prevalence of this disease in that group? It could be any question. The point that makes it a systematic review is you try and get everything and you've got a plan for bringing it together, essentially. So no, not just interventions. But I think the methodology was developed largely for the intervention studies, and we're much better at doing systematic reviews for interventions than we are for other types of questions, because we've got a much better handle and consensus on what a good review looks like. So Steve was saying earlier, he's got a few reviews going on about observational data, and they're a lot more horrible to do than reviews of interventions. He's nodding sagely. For Jessica's benefit, he's nodding sagely like a man who's been damaged through his experiences. Once you've got your effect size.
They burn PhD students as well.
Once you've got your evidence, so we've looked at the quality or risk of bias of the individual studies. But once we've got our effect estimate or our conclusion, we then really want to have some kind of estimate of, well, what's the quality of this evidence, the body of evidence, not the individual studies. And an approach that's getting much more widely adopted now, there's a lot of consensus on it. It's not perfect by any standards, but if we can get everyone doing something similar, it's much easier to understand the evidence. It's the grade approach. And the grade approach is just a systematic approach to saying, what's the quality of this body of evidence? Or rather, really, it's about what's the level of uncertainty relating to this body of evidence. So with the grade approach, if you've got evidence just from RCTs, you start from a position that we've got high quality evidence, because if they're done well, all things being equal, they're our gold standard, right? And we all understand why they're the best method for this type of question. But we might downgrade that evidence. And the things that we'll downgrade it on are limitations in the included studies. So if lots of your studies are at risk of bias, well, that's going to downgrade it. So we might downgrade once. You could even downgrade twice if the studies are truly awful on the basis of that risk of bias. So you might downgrade from high to moderate or from high to low, okay? You'll downgrade if your effect estimate is very imprecise. You'll downgrade if there's lots of heterogeneity in the effect estimates between the studies, that the studies are quite inconsistent. And you'll downgrade if there's evidence of sort of a structural publication bias in the evidence too. So you could actually, as we often do, end up at very low, still finding reasons to downgrade, but you don't go further than very low, because if it's very low quality evidence, that tells you what you need to know. It doesn't just work one way though. It might be that you actually started with observational data for a different type of question, but there might be some factors, it's much harder to upgrade evidence, but that allow you to upgrade. So consistency across studies, large effect sizes, strong dose-response relationships, are all reasons we might upgrade a body of evidence. So if we took smoking for cancer, we have huge body of evidence, consistently large effect sizes, a clear dose-response relationship, the more you smoke, the higher your risk, and a clear reversibility relationship. When you take the exposure away, the risk starts to drop again. So you can upgrade from low with smoking, because actually there's very little uncertainty that smoking is causal agent for lung cancer, right? Does that make sense? Totally. I mean, you operationalize how you'll do it, and you might set some thresholds for what imprecision looks like, or how much inconsistency there are. And we'll talk about that when we get into the meta-analysis. It'll be the final conclusion for each comparison you make. So if you look at Cochrane reviews nowadays, they will have a summary of findings table. So it will say something like, I don't know, motor control exercises versus usual care for back pain short term. There's the effect estimate, and we grade that body of evidence that's driven that estimate as high, low. If it's high, there's very little uncertainty. We don't expect future evidence to change it. If it's very low, we're very uncertain about the effect estimate. If it's low, we're quite uncertain, and there's a high probability that future evidence might change that estimate. So that's how we use it. But it's totally, there is a lot of judgment involved. It's never as clear cut as we'd like it to be. And there are interesting discussions that go around grade judgments. So, you know, we can assume then we've got they're right at the top of the tree. We can trust systematic reviews, right? I mean, they're the gold standard of the gold standard. But actually, just like everything else, you know, the thing about reviews is that people do them, and people aren't great at doing things often. Years ago, this old systematic review in 2002 found that overall, the quality of systematic reviews was very low. And Cochrane reviews were a bit better, but still not great. Now, Cochrane is quite an active organisation that continually try and improve consistency and quality in reviews. I think if they did that review now, it would be better, but it wouldn't be perfect. Okay, and I think it's just coming back to that idea that if you just assume that something's good because it's branded Cochrane, you're delegating responsibility for really looking at it and deciding if it's good. In the same way you are if you just believe the research or read the conclusion of the abstract. But of course, when you're making your nuanced judgments, if you've got no time and you're doing shortcuts, there are some authorities that are lower risk of being wrong than others. But it's all a continuum. Okay. Yeah, well, exactly that, right? We did an overview. This is data from an overview of systematic reviews of all interventions for CRPS. It was the first one of these sorts of studies I did. And I have to say that it was harder than we thought it would be. And some of our methods they developed as we went, although we've been very transparent about that. But we assessed the quality of systematic reviews using a tool that's supposed to identify things that make a good and bad review, the AmStar score. And just have a look across this. This is by no means representative. This is just from our review. But you might see a reasonably clear difference between the two different reviews. And this is how they scored when they were Cochrane and non-Cochrane. Now, of course, I've got a conflict of interest because I'm an editor with Cochrane. But there's another side to this as well. All these reviews were published in journals with word limits. Cochrane is all published online, has no word limits, and encourages complete presentation of all the data. So these guys had a total advantage in that they can show everything because it all goes online. And these guys were fitting in to the restrictions of a journal. Having said that, some of these reviews were truly shocking. And, were systematic by virtue of the name in the title rather than by virtue of being systematic. So then once you've got your review, you ask, what does it mean for my practice? And again, like always, you're back to PCOS and the effect size, the CAST tool you're going to use. I mean, look at these questions. And you notice across all the CAST tools we've done so far, the questions don't differ so much, do they? There's no great complexity to the actual process of critical appraisal. There's complexity in some of the detail. But if you understand the right questions to ask, then it's all to the good. There's another issue. When we only search for published reports of data, and this isn't the same issue as publication bias. This is the issue of what goes into a journal article. So if you're developing a new drug and it goes to the FDA or the European Agency for Drug Regulation, then you don't give them a journal paper. You give them a document like that. Right? I went on a workshop at Cochrane recently about that, regulatory data. So these huge full clinical study reports, they're enormous. In there is every adverse event form, pretty much everything's in there. And that's what goes to the regulator. What gets published is that packaged into the format for a journal. And when you start digging, not me, but when some guys from Cochrane who are really interested in this as a topic start digging, you realize that some of the information in the journal report doesn't quite match the information in the CSR. And it isn't harmless in that respect. So it's some really good examples. Tamiflu is probably one of the greatest frauds in some ways placed on healthcare systems. I don't know if America did, but in the UK, we stockpiled Tamiflu because there was an awful lot of worry about a major flu pandemic. And Tamiflu had been shown to prevent flu-related pneumonia, which is, of course, the reason flu kills so many people. One of the major trials driving that, published the journal paper, shows that it does. When you go into the clinical study report and ask, how did they ascertain pneumonia? They ascertained it by asking people, have you had pneumonia? With no formal process of identifying it. when you look at studies that have some sort of formal diagnostic process, there's no signal. So government spent an enormous amount of money on this drug because they thought there was a huge public health concern, driven by information in journal articles that didn't match the detail in the regulatory data. But the regulatory data is so massive, no one's going to go through it in enough detail. It's the same with adverse events. So there's a really good example from Siroxat, where adverse events were classified as things like emotional lability in teenage depressants. It was suicidal ideation, but it was classified as emotional lability. A suicide attempt was classified as a skin laceration. Now, you know, it's hard not to be disgusted by that. And it's also easy then just to say industry bad. And I think it's much more complicated than that. But there is a body of people in Cochrane, and it's certainly not the popular view yet, that when we're doing systematic reviews of published papers of interventions from industry, what we're really doing is we're reviewing marketing documents. And the only way we really get to the truth is to get hold of the CSRs. But there are real freedom of information problems with accessing the CSRs at the moment, although there is progress and lobbying on that. It's not something I don't think you need to worry about. I just think it's a really interesting thing that's kind of political and arising at the moment. And that's systematic reviews. Any questions? Cool, so we will look at meta-analysis. Do I need to do anything when putting up the...
Well, one, do you want anything up there? But let's stop the recording. Can I stop the recording?
Yeah.
Mm-hmm.